Welcome to our comprehensive guide on common medical emergencies and their management in dental practice. In this video, we'll walk you through the most frequently encountered emergencies, their symptoms, and practical solutions for each. Dental clinics are unique environments where anxiety, pain, and medical conditions can trigger sudden health crises. Understanding how to recognize and respond to these emergencies is crucial for patient safety and effective care. We'll cover everything from syncope and hyperventilation to allergic reactions, hypoglycemia, angina, seizures, drug overdose, choking, hypotension, hypertension, and cerebrovascular accidents. Let's begin by setting the stage for why preparedness matters and how these emergencies can arise unexpectedly during routine dental procedures. Vasovagal syncope is the most common medical emergency in dental practice. It's defined as a sudden, transient loss of consciousness with spontaneous recovery. This condition is often triggered by extreme anxiety, fear, or pain, leading to a temporary reduction in blood flow to the brain. The underlying mechanism involves a vagus-mediated reflex bradycardia, sometimes accompanied by peripheral vasodilatation. Patients may experience lightheadedness, dizziness, pallor, nausea, sweating, visual disturbances, and fainting. The pulse is typically slow and feeble due to bradycardia and hypotension. Recognizing these signs early is essential for prompt intervention and patient safety. Prevention is always better than cure, especially when it comes to syncope. Stress reduction protocols, effective communication, and reassurance are key strategies to prevent episodes of syncope in dental settings. By addressing patient anxiety and creating a calm environment, dental professionals can significantly reduce the risk of fainting. It's important to assess each patient's stress level and provide support throughout their visit. Simple measures like explaining procedures, offering breaks, and maintaining a friendly demeanor can make a big difference. Let's explore how these preventive steps can be integrated into daily practice for safer patient care. When syncope occurs, immediate management is crucial. The patient should be positioned in a supine position with legs slightly raised to improve venous return and cerebral perfusion. Aromatic ammonia from the emergency kit can be used as a respiratory stimulant, helping the patient regain consciousness quickly. It's vital to assess the airway and monitor other vital signs. Oxygen may be administered through a ventimask or nasal cannula if needed. For cases where hypotension persists, further management protocols are discussed in the hypotension section. These steps ensure rapid recovery and minimize complications. Hyperventilation is another common emergency, often triggered by extreme anxiety and fear. Patients begin to breathe rapidly and deeply, consciously overdriving their ventilation. This leads to excessive washout of carbon dioxide, causing decreased partial pressure of arterial CO2, PaACO2 below 35 mm Hg. Hypocapnia results in constriction of cerebral blood vessels, producing lightheadedness and dizziness. Continued hyperventilation can cause respiratory alkalosis, raising blood pH to 7.55. The release of catecholamines leads to palpitations, tachycardia, trembling, and sweating. The abnormal sensations and anxiety create a vicious cycle, making the patient hyperventilate even more. Patients experiencing hyperventilation may develop tingling, muscular twitching, and carpal pedal tetany-like features due to hypokalemia and hypocalcemia. The excessive release of catecholamines intensifies symptoms such as palpitations, tachycardia, trembling, and sweating. These sensations, coupled with anxiety, often make the patient hyperventilate even more, perpetuating the cycle. Recognizing these symptoms early is important for breaking the cycle and providing effective management. Dental professionals should be alert to these signs, especially in anxious patients, to intervene promptly and prevent escalation. The key to managing hyperventilation is breaking the vicious cycle. Patients should be reassured and guided to breathe slowly and normally. Unlike other emergencies, oxygen therapy is not recommended for hyperventilation. The outdated practice of rebreathing into a paper bag should be avoided, as it can lead to dangerously high CO2 levels. Instead, the most effective method is to have the patient breathe through cupped hands in front of their nose and mouth, or use a detached oxygen mask with holes for CO2 release. In most cases, these steps will terminate the cycle. Sedation with diazepam or midazolam may be required in certain situations. Asthma is characterized by increased contractile response of smooth muscles in small airways and can be triggered by allergies or non-allergic factors. In dental settings, asthmatic attacks may occur due to anxiety, aerosolized particles, or certain drugs like aspirin and NSAIDs. Symptoms include coughing, wheezing, dyspnea, and hunger for air. Asthmatic patients usually carry their bronchodilator inhalers, and prophylactic use before appointments is advisable. Having a bronchodilator inhaler readily available at chairside is essential for quick response. During an asthma attack or bronchospasm, the patient should be seated upright and oxygen administered via mask or nasal cannula. The patient is instructed to take puffs from their own inhaler or a salbutamol inhaler from the emergency kit, repeating every minute for up to 5 minutes or until symptoms improve. Inhaled medication is as effective as intravenous medication. For severe cases, intravenous salbutamol or hydrocortisone may be considered, and IM epinephrine can be used as a last resort. Oxygen should be given at 4 to 6 liters per minute, and vital signs monitored with a pulse oximeter, maintaining saturation above 90%. Seek medical help for life-threatening signs. Allergic reactions occur when the body's immune system responds to a substance, allergen to which the patient has been previously sensitized. These reactions range from mild skin symptoms to life-threatening anaphylaxis. Common allergens in dental practice include antibiotics, local anesthetics, and latex. Penicillin and its derivatives are known to cause allergic reactions, including true anaphylaxis. The most commonly affected organ is the skin, resulting in itching, redness, and rash. Severe cases may involve bronchospasm, laryngeal edema, and laryngeal spasm, which can be life-threatening if not managed promptly. Anaphylaxis is a true emergency requiring prompt diagnosis and urgent management. Key drugs for managing allergic reactions include antihistamines, epinephrine, and hydrocortisone. Pheniramine maleate is used for slow-onset skin reactions, while epinephrine is the treatment of choice for anaphylaxis. Epinephrine rapidly resolves symptoms by reversing histamine action and blocking further release. Adult dose is 0.3 mg IM, or 1 to 3 milliliters of diluted solution IV. Supportive care includes airway maintenance, monitoring vital signs, and oxygen administration. Rapid infusion of normal saline helps overcome fluid shifts. Hydrocortisone can be given once the patient is stabilized. In severe cases, cricothyrotomy may be needed to secure the airway. Diabetes mellitus is prevalent, and patients are prone to hypoglycemic and hyperglycemic events. In dental settings, hypoglycemia is more common and dangerous, while hyperglycemia develops over days or weeks. Hypoglycemia results in confusion, restlessness, headache, bizarre behavior, and can lead to loss of consciousness. Hyperglycemic patients may have flushed, dry skin, low blood pressure, and fruity breath due to ketoacidosis. Monitoring blood glucose with a glucometer helps differentiate between the two. Prevention involves ensuring diabetic patients do not miss meals before or after dental treatment. If hypoglycemia is evident, it can be corrected by giving glucose or sugar to drink or chew in conscious patients. For unconscious patients, 25-50 milliliters of 50% dextrose should be administered intravenously. Alternatively, 1 milligram of glucagon can be given intramuscularly. Vital sign monitoring, and basic life support protocols should be followed, as with any unconscious patient. Emergency management of hyperglycemic patients is supportive, and they should be shifted to a nearby hospital for definitive care. These steps ensure patient safety and prevent complications. Angina is chest pain due to inadequate blood supply to the heart, often triggered by stress, anxiety, or exercise. Pain is brief and usually resolves within 5 minutes without permanent damage. Acute myocardial infarction occurs when a clot develops in a coronary artery, causing permanent damage to heart muscle. Both conditions present with chest pain, heaviness, shortness of breath, nausea, and pain radiating to shoulders, arms, neck, jaw, or upper abdomen. Recognizing these symptoms early is vital for effective management and preventing progression to cardiac arrest. The goal in managing chest pain is to decrease the heart's oxygen requirement or increase its supply. Supplemental oxygen is administered via mask or nasal cannula. Nitroglycerin is the most effective vasodilator for angina, given as sublingual tablets or spray. A 0.4 mg tablet is placed under the tongue every 5 minutes, up to 3 tablets in 15 minutes. Nitroglycerin may cause flushing, headache, tachycardia, and hypotension, so it's contraindicated in cases of concurrent hypotension. For acute myocardial infarction, antifibrinolytic aspirin is recommended, and the patient should be shifted to a cardiologist as soon as possible. If myocardial infarction progresses to cardiac arrest, basic life support (BLS) and cardiopulmonary resuscitation (CPR) protocols are initiated. The goal is to restore normal heart rhythm using an automated external defibrillator (AED). Immediate action is critical for survival and minimizing long-term damage. Dental professionals should be trained in BLS and CPR, and emergency equipment should be readily accessible in the clinic. Early recognition and intervention can make a life-saving difference in these situations. Seizures or convulsions are abnormal electrical activities in the brain, resulting in changes in consciousness, motor activity, or sensory phenomena. Most patients have epilepsy as the underlying cause, but hypoglycemia, hypoxia, or local anesthetic overdose can also trigger seizures in dental settings. Typical tonic-clonic seizures involve major skeletal muscle contractions, loss of consciousness, apnea, cyanosis, and tongue biting. The clonic phase features alternating muscle relaxation and contraction. Most seizures are self-limiting, lasting 1 to 2 minutes, followed by postictal drowsiness, fatigue, and confusion. During the active phase of a generalized seizure, never attempt to restrain the patient's movements or place any object in their mouth. These actions can cause harm. Instead, turn the patient to their side to protect the airway and place protective padding under their head to prevent injury. After the seizure, continue monitoring the airway and vital signs. Oxygen can be administered via mask or nasal cannula. For status epilepticus, diazepam 10 mg can be administered intravenously over 2 minutes to stop seizure activity. Children receive a dose of 0.2 to 0.5 mg per kilogram IV. Referral to a neurologist is recommended for medication adjustment. Drug overdose reactions can occur due to excessive doses, inadvertent intravascular injection, or rapid administration. Local anesthetic overdose is common in dental clinics, and clinics using pharmacosedation may see opioid or benzodiazepine overdoses. Lidocaine toxicity presents with restlessness, agitation, confusion, blurred vision, ringing in ears, muscle fasciculations, tremors, or seizures. Depressive phase symptoms include hypotension, bradycardia, respiratory, and cardiac arrest. Recognizing these signs early is essential for prompt intervention. Management of lidocaine overdose involves maintaining airway and circulation, administering oxygen, and monitoring vital signs. Basic life support measures are instituted as there is no antidote for lidocaine toxicity. Supportive care continues until the patient recovers. Naloxone is the antidote for opioid overdose, reversing respiratory depression. It's administered as 0.4 milligrams IM or IV, with a short duration of action, requiring close monitoring for resedation. Flumazenil is used for benzodiazepine overdose, administered IV every 1 to 2 minutes up to 1 milligram. Patients should be observed for at least 1 hour post-reversal. Choking or foreign body aspiration can occur when dental instruments, extracted teeth, or materials slip into the oropharynx. Most swallowed objects pass through the gut without complications, but sharp objects require urgent gastroenterologist consultation. The glottis is the narrowest part of the airway in adults, while the subglottic area is narrowest in children under 5. Depending on the size, the object may lodge in the larynx or bronchus, causing partial or complete airway obstruction. Severe obstruction is life-threatening and requires urgent removal. If the object can be seen, it may be removed using Magel's forceps or high-volume suction apparatus. A laryngoscope can improve visibility during the procedure. The patient may be encouraged to cough and expectorate the object. If these methods are unsuccessful, surgical intervention may be necessary. The American Heart Association recommends maneuvers such as the Heimlich maneuver and abdominal thrusts for expelling foreign bodies. Children under 1 year require a combination of back slaps and chest thrusts while maintaining a head-down position. Cricothyrotomy is recommended for establishing airway patency in emergencies, as it has fewer complications than tracheostomy. The procedure involves making an opening in the cricothyroid membrane with a scalpel, followed by insertion of a tracheostomy or endotracheal tube. Commercial cricothyrotomy kits are available and should be kept in the emergency kit. Alternatively, a 13-gauge needle can be used to puncture the membrane. Once the airway is secured, the patient can be ventilated and stabilized before further management. Hypotension, or low blood pressure systolic below 90 mm Hg, can lead to inadequate cerebral perfusion and loss of consciousness. The most common cause in dental settings is vasovagal syncope, associated with bradycardia. Changing the patient's position to supine with legs elevated usually results in recovery. Persistent hypotension may require medication. Hypovolemia is another cause, especially in fasting patients. Elderly patients may experience orthostatic hypotension when standing after prolonged appointments. Raising the chair slowly and asking patients to get up gradually can prevent episodes. 2 medications are useful for managing hypotensive episodes. When hypotension is accompanied by bradycardia, atropine is administered at 0.5 milligrams IM or IV, repeated every 5 minutes up to 3 milligrams. Rapid infusion of normal saline may be needed to increase blood pressure. Ephedrine is helpful for increasing systolic pressure in patients with normal heart, given as 25 milligrams IM or sublingual injection, repeatable every 5 minutes. Phenylephrine is used when the patient has normal heart rate or tachycardia, administered IV in increments with close titration. These interventions help restore blood pressure and prevent complications. Transient episodes of hypertension may occur in patients with extreme pain or restlessness during lengthy procedures. Most cases require only a timeout to calm down. If accompanied by symptoms like chest pain, headache, or visual disturbances, drug intervention may be needed. When stroke is suspected, no attempt should be made to lower blood pressure. Known hypertensive patients who miss their medications should be given their usual dose. Esmolol, a selective beta-1 blocker, can be used for acute hypertensive events, with dose titrated to repeated measurements. Esmolol is rapidly metabolized and has a brief duration of action, making it suitable for acute hypertensive events. It's administered as 0.5 milligrams per kilogram over 1 minute, with 20 milligrams increments every 1 to 2 minutes. Dose is titrated to repeated measurements of blood pressure and heart rate. Earlier practices like sublingual nifedipine are no longer recommended due to risks of myocardial infarction or stroke. Esmolol is also helpful in managing narrow complex tachycardia and supraventricular tachycardia. Proper monitoring and titration are essential for safe management. Cerebrovascular accident stroke and transient ischemic attack, TIA, are caused by interruption of blood supply to the brain. Patients are usually elderly with uncontrolled hypertension, diabetes, and atherosclerosis. TIA symptoms are short-lived and recover spontaneously within 24 hours, including slurred speech, temporary numbness or paralysis, monocular diplopia, and loss of balance. TIA is a warning sign of a major ischemic event requiring immediate referral to a neurologist. Early recognition and intervention are crucial for favorable outcomes. Stroke symptoms include altered consciousness, headache, nausea, vomiting, inability to speak, facial paralysis, paresthesia, and hemiplegia. Management consists of recognition and urgent transfer to a hospital. Early intervention is crucial for favorable outcomes in certain types of stroke. While arranging transport, basic life support measures such as positioning to prevent aspiration, suctioning to maintain airway, monitoring vital signs, and oxygen therapy are important. Dental professionals should be prepared to act quickly and efficiently in these situations. Let's recap the key points covered in this guide. Dental clinics can encounter a wide range of medical emergencies, from syncope and hyperventilation to allergic reactions, hypoglycemia, angina, seizures, drug overdose, choking, hypotension, hypertension, and stroke. Early recognition, prompt intervention, and proper management protocols are essential for patient safety. Having an emergency kit, trained staff, and clear procedures ensures rapid response and minimizes complications. Preparedness and vigilance are the cornerstones of effective emergency management in dental practice. A well-stocked emergency kit is vital for managing medical emergencies in dental clinics. Essential items include oxygen delivery systems, airway management tools, antihistamines, epinephrine, hydrocortisone, glucose, dextrose, glucagon, nitroglycerin, aspirin, diazepam, naloxone, flumazenil, atropine, saline, ephedrine, phenylephrine, esmolol, and cricothyrotomy kits. Regular checks and staff training ensure that all equipment is functional and accessible. Having these tools readily available can make a critical difference during emergencies. Effective communication is crucial during medical emergencies. Dental professionals should remain calm, provide clear instructions, and reassure patients and their families. Coordinating with emergency services, keeping records of interventions, and updating the patient's medical history are important steps. Good communication helps reduce anxiety, ensures smooth teamwork, and improves outcomes. Training staff in emergency communication protocols is an essential part of preparedness. Monitoring vital signs is a fundamental aspect of emergency management. Regular checks of blood pressure, heart rate, respiratory rate, oxygen saturation, and consciousness level provide valuable information for decision-making. Pulse oximeters, blood pressure monitors, and ECG devices should be available in the clinic. Early detection of abnormal vital signs allows for timely intervention and improves patient outcomes. Training staff in proper monitoring techniques is essential for effective emergency response. Basic life support (BLS) is a critical skill for dental professionals. BLS includes airway management, breathing support, circulation assessment, and use of automated external defibrillators, AEDs. Regular training and drills ensure that staff can respond quickly and confidently during emergencies. BLS protocols should be reviewed and updated periodically to reflect current guidelines. Having a designated emergency response team in the clinic enhances preparedness and patient safety. Educating patients about their medical conditions, medications, and emergency protocols is an important part of dental care. Patients should be informed about the risks of missing meals, medication schedules, and potential triggers for emergencies. Providing written instructions and emergency contact information helps patients feel secure and prepared. Encouraging patients to bring their inhalers, glucose tablets, or other necessary medications to appointments can prevent emergencies and facilitate rapid intervention. Regular staff training and emergency drills are essential for maintaining readiness in dental clinics. Training should cover recognition of emergencies, use of emergency equipment, medication administration, communication protocols, and basic life support. Drills help staff practice their roles and improve response times. Reviewing case studies and learning from real-life scenarios enhances knowledge and confidence. Continuous education ensures that the team is prepared for any emergency. Accurate documentation of emergency events, interventions, and outcomes is vital for legal and clinical purposes. Records should include patient details, symptoms, actions taken, medications administered, and follow-up recommendations. After an emergency, patients should be referred to specialists as needed and their medical history updated. Follow-up appointments ensure ongoing care and prevention of future emergencies. Good documentation supports quality improvement and patient safety. Vasovagal syncope is a sudden, transient loss of consciousness due to a temporary reduction in blood flow to the brain. It's commonly triggered by anxiety, pain, or fear in dental settings. The underlying mechanism involves vagus-mediated reflex bradycardia and peripheral vasodilatation. Recognizing the signs, dizziness, pallor, nausea, sweating, and fainting is essential for prompt intervention. Management includes positioning, airway assessment, and oxygen administration. Hyperventilation is rapid, deep breathing caused by anxiety or fear, leading to excessive loss of carbon dioxide and respiratory alkalosis. Symptoms include lightheadedness, dizziness, palpitations, and tingling. Management focuses on breaking the cycle by reassuring the patient and guiding slow, normal breathing. Oxygen therapy is not recommended, and cupped hands or a detached mask can help restore normal CO2 levels. Anaphylaxis is a life-threatening allergic reaction involving multiple organ systems. It's triggered by exposure to allergens, such as antibiotics, anesthetics, or latex. Symptoms include skin rash, bronchospasm, laryngeal edema, hypotension, and cardiac arrest. Management requires immediate administration of epinephrine, antihistamines, and supportive care. Securing the airway and monitoring vital signs are critical steps. Hypoglycemia is a sudden drop in blood glucose levels, leading to confusion, restlessness, headache, and loss of consciousness. It's more common in dental settings than hyperglycemia. Management involves administering glucose or sugar to conscious patients, IV dextrose or IM glucagon to unconscious patients, and monitoring vital signs. Prevention includes ensuring diabetic patients do not miss meals before or after dental treatment. Angina is chest pain due to reduced blood supply to the heart, often triggered by stress or exercise. Myocardial infarction is caused by a clot in a coronary artery, resulting in permanent heart muscle damage, both present with chest pain, nausea, and breathlessness. Management includes oxygen, nitroglycerin for angina, aspirin for infarction, and urgent referral to a cardiologist. Cardiac arrest requires BLS and CPR protocols. A seizure is an abnormal electrical activity in the brain, causing changes in consciousness, motor activity, or sensory phenomena. Common causes include epilepsy, hypoglycemia, hypoxia, and drug overdose. Management involves turning the patient to their side, protecting the airway, and administering oxygen. Diazepam is used for status epilepticus. Referral to a neurologist is recommended for ongoing care. Choking occurs when a foreign body obstructs the airway, requiring urgent removal. The Heimlich maneuver and abdominal thrusts are recommended for expulsion. Cricothyrotomy is a surgical procedure to establish airway patency in emergencies, involving incision of the cricothyroid membrane and insertion of a tube. Commercial kits are available for rapid intervention. Early action is critical for survival. In conclusion, preparedness, vigilance, and proper training are the keys to managing medical emergencies in dental practice. Early recognition, prompt intervention, and effective communication ensure patient safety and optimal outcomes. Regular staff training, emergency kit maintenance, and patient education are essential components of a safe and responsive clinic. By following these guidelines, dental professionals can confidently handle emergencies and provide high-quality care.